some people might not be attending and what we should be doing about it. So next slide, please. Now, I'm hoping this little clip will play. It's actually been devised from Gloucestershire, and if the link's still there, thank you.
Hello, Dr. JP, I'm talking to you. Would you mind not writing that? I didn't choose not to come to my appointment. I've been waiting here for ages. I can't come on my own. My carers couldn't bring me in today. One had phoned in sick.
Oh, what a shame. We've got a bit of buffering going on.
One had a problem with his car. One, she didn't show up this morning. And everyone else is busy trying to get us all ready. So, you see, it really wasn't my fault. I wanted to come and see you today, but I wasn't brought. Instead of writing "did not attend" on my file, you should write "was not brought."
Oi, Doc, don't forget about me. You keep writing "did not attend" on my files too, and I don't think that's fair. First off, your receptionist keeps giving me early morning appointment, and that just doesn't work for me. I guess I'm not what you'd call a morning person. Plus, the idea of having to go to a surgery makes me feel really weird and anxious. I get worried and upset and often miss my appointment because I can't calm down. It's ironic, really, because this is probably something I should discuss with the doctor. And even if I had made it out the front door, I hate transport, except for trains. I don't like buses. There's too many people. And we can't use the car today. Please don't write "did not attend."
I think we might need to pause that video because it's actually sounds out of sync with the pictures, which is nobody's fault. It's just unfortunate. So we'll just pause it there. Anna, thank you so much. So we will have a slide.
Can I just quickly mention there's just a couple of minutes left of this slot?
Yes.
Yeah.
Thank you very much indeed. So I am coming to a close now simply because that video was going to take me to the end very eloquently. So it's a very nice bit, and I recommend you look at it because it just makes a very point better than I can. Now, these slides, I'm not expecting anybody to read them, but basically this is an example of the work that North Cumbria has been doing, by which they're putting together some guidance. They've actually rag rated it, so you can see, and then they've got, you know, like the top line there is what's the impact of the missed appointment with some actions underneath. What's the next slide, please? And then this is about actions you should take. So quite a lot of actions depending on how concerned you are. And then the third slide, please, on this. Thank you. And then this is just about thinking about what you want to get out of your actions. So I'll find a way of getting that more neatly onto something like TeamNet or as a resource for you. But I think it's worth starting to think about that adult not brought code and not not assuming people are just DNA as a matter of choice. Thank you very much. So that's briefly on that topic. We're now going to move over to my colleagues, and I confess I don't know exactly who's going to be talking today, but we've got the children, young people and families team, and I wonder if you'd just like to introduce yourselves and explain who's going to be talking.
Hi Claire, it's Dawn Robson. So I'm Dawn Robson, I'm the nurse coordinator with the Children, Young People and Families team. So I'm going to talk a little bit about the SEND agenda and how that links with learning disabilities.
Thank you very much. So you'll get a 5-minute warning at 3 o'clock.
Right. Okay. Sorry, I've just lost my information. Really sorry, I've lost my information here.
Dawn, do you want me to help out there?
Yeah, my computer's just absolutely dying, and I just can't find my notes that I've made.
When you get there, tell us, because you'll do a much better job than me. Hello, everybody. I'm Catherine Horn. I'm the Portfolio Manager for Children and Young People and Families and work with Dawn. And we just wanted to update you really around the work we've been doing to support the SEND agenda on the learning disability health checks. We're very much working with the Children and Young Families team response to 14 plus, inviting along to the practice for LD health checks, what primary care can do when the young person comes along. And we're also trying to tie that up with working alongside the schools and how they can help promote and encourage those young people to come along for the learning disability health check. And it's pretty much about trying to explain to young people and families and their parent carers how that check works and how reassuring it can be to come along and have one of those checks and the benefits to them. Can we have the next slide, please, Anna? So as a team in the CCG, we've been trying to work with general practice to find out what works well for them when undertaking a learning disability health check for a young person, especially those harder to reach young people who are nervous about coming into practice. So Dawn met with a number of practices to find out how they encouraged young people to come in for learning disability health checks and develop some good practice guidelines, and they were recently shared in the weekly bulletin, and they're also on GP TeamNet for you to have a look at. What we tried to do on the back of that was also develop that resource into a resource that schools could use so they could understand the importance of the learning disability health checks and understand that, because we had noted that schools and parent and carers weren't really aware of the LD health checks and how to go about undertaking one. So Dawn's done some significant work around that also. It basically really is trying to put that into a easy read format as well, and it's encouraging what is the LD health check about, and sometimes it's not necessarily using the LD word, just encouraging that health check and why it's important to come along. There's a flow chart that describes what happens at different stages and that's for primary care and schools. And as I mentioned, the guidelines around different areas of good practice that people may want to adopt to read. We've done the easy read guidelines for schools, but what we want to do is do some easy read guidelines for young people themselves so they can take ownership. So if anybody would like to work with us in practices and find some young people to work on, we'd really welcome that to try and encourage that better uptake of those checks at that stage. Anna, can we have the next slide, please? And really about promoting using the EMIS template to record your LD health checks on and make sure that all the boxes are completed and ticked, because we find that sometimes it'll look like in practice you've undertaken that LD health check, but if that template hasn't been completely filled in, it won't show out on the data in the action health plans as well. These are really important that we start to see these being developed and getting the young people to own those action plans once you've developed them with them. Next slide, please, Anna.
Do you want to take over if you want me to take over?
Yes, you'll do much better than me. Thank you.
You've done it all. I'm really sorry about that. So really what we're wanting to think about, what can primary care do? And in this section, we're going to look at the potential benefits for completing the annual health check. We're doing a lot of work with the local authority to ensure that our young people are being invited for the health check from the earliest point, so at 14 years. So they've recently revamped all of the annual review documents for that schools will be completing in at the annual review of an education, health and care plan. And at that point, they're going to be checking if there's a child or a young person eligible, then they will be offered. The reminder will be given. We realise that there might be a lot of young people who are well at this point, but it is a good starting point if they have some reluctance or fears about attending a GP surgery. Usually you would go, when you're unwell, but during this time it might be possible to find out, how they communicate, what support they have in place, and identify any safety issues. If they are well, it might be a good opportunity to promote the healthy lifestyle, but also identify if there are any problems which haven't been previously noted. It's also a good opportunity to promote screening, immunisations, as well as reviewing any of the medication that they're already taking. And the main goal and benefit to doing these checks obviously is, from that early stage, to help that transition into adult services much easier if they're comfortable already attending the GP practice. Next slide, please, Anna. So obviously we realise that transition is often a very difficult time for young people and their family. Previous services that well known to, they're not going to be received in those ones in the future. Or you can support this and ensure that the services or equipment that they still do need will be there for them on transition. Thinking about identifying disease and health difficulties at an early stage. So with the annual health check and completion of the health action plan, you can support detecting any commonly missed problems such as hearing and sight problems. And as you know, disabled people are more at risk of abuse. It's a good opportunity for you to ask those additional questions. Maybe think about county lines, hate and hate crime, any neglect issues. All can be discussed in a relaxed environment. And as we know, disabled children have that added risk of abuse as well. Next slide, please, Anna. So we thought it might be useful to include this slide with the presentation so that you can take away a copy of the recommendations from the Royal College of GPs if you don't already have it. So thinking about needing to make those reasonable adjustments for your patients using that teach principle. And just really, sort of think about those patients who they may need a room away from the general waiting area and a quiet environment until their appointment time, or those patients who may benefit from the first appointment in the morning as they're unable to wait for appointments generally. And it kind of links in a little bit with the information Claire was talking about in relation to not being brought. And maybe these are some of the reasons that the patients aren't attending. Next slide, please, Anna. So obviously the health action, that's gone into a different, format. I think we've already talked about those. You missed that one. Yeah, so really the three key things to take away from our session this afternoon, just to ensure that EMIS template is completed fully, all boxes are ticked, and looking at the good practice guidelines that we've recently developed to see if there is some tips in there that might be useful for your practice to support engaging those hard to reach patients, and also the health action plan, just to make sure that's completed alongside the annual health check. And obviously to use those teach principles when making those reasonable adjustments, just to make sure that the annual health check is successful for them. Thank you.
So thank you very much. So I'm just wondering if there are any questions in the chat.
No questions in the chat, Claire.
Okay, so I was just going to ask a question of Dawn and Catherine, if I may. So I was just wondering in this work whether you're coming across any confusions or challenges around the language of learning difficulty versus the language of learning disability, which we have discussed in different timeouts. But does that come up as a problem?
Yeah, shall I take that one, Dawn? It does, Claire, all of the time. And Dawn recently attended a careers event at the local authority for post-16 learners. She had lots of parents and carers and young people come to talk to her, but in particular a school who raised that just in the last fortnight around how it's a problem getting access for their young people to, you know, not only just health checks, but lots of other things, including social care. That school's actually invited us to go in and talk to their young people, but also we're thinking of doing a bit of a pilot work with them to identify how many people in that school have got that learning disability diagnosis already, the ones that they feel like don't have it but are going to struggle on that transition period. So that's an initial piece of work we're going to try and do, to have a look at that. And it's really good that a local school wants to work with us to do that. But yes, it comes up quite a lot, I'm afraid.
Yes. Yes, no, thank you. And I think we've touched on this before, that the language of special educational needs code of practice and the language of health is quite different, and it does have some unintended consequences sometimes. So thank you for that. Okay, so thank you. That was great. If there are no more questions, have we got Barry on the call?
I don't think Barry's on here yet, Claire.
Right, okay, right. So fine. So I think I'd asked him to join by 3.
Claire, I was just going to say, when you were talking about barriers, one of the other things that I'm always keen to mention is when we're talking about the SEND agenda and learning disability health checks in the community, the words that we use. It was very interesting when I started to work with the local authority. EHCP means very different things in local authority and school landscapes to ours. So we'll automatically think in health as emergency healthcare plans, but schools, you know, we're saying, oh, I asked for how many EHCPs, and they obviously didn't get education healthcare plans back, they got emergency healthcare plans back. So I always just try and say that wherever I am, and I know people probably hear it every time they hear me, but I think it's always just really clear to try and pass that message on, that we've got to be really clear about an EHCP as an emergency healthcare plan or an education healthcare plan. And this is where it comes really muddied when you start talking about learning disability health checks, because you use the two terminologies interchangeably. So it's just that little reminder that if somebody contacts you, it might not be an emergency healthcare plan. If they're talking about an EHCP, it might be an education healthcare plan.
Yes, thank you. Again, language that can trip us up, isn't it? Aims to facilitate. So yes, thank you.
Claire, we've got something in the chat.
Thank you.
Could you go over the action plan a bit more, please, and what services are available to help transition?
So the health action plan, obviously you have a template on your clinical system when you're talking to the patient, and really it's just to support you to keep that patient healthy. Talk about, you know, sort of what's available in your area, what tells you what you need to do to keep healthy, what services support you need to lead a healthy lifestyle, and obviously the leaflets and things like that can be given to the patient when it's being discussed. It's just to make sure really that the patient's understanding that as well, what is being asked, and you know that they have got all of the information that they need to make those healthy choices.
Thank you. And I think thinking as well about the local offer, maybe, I don't know if one of you wants to comment about that, because that's a good resource for young people, isn't it, to think about social and wellbeing activities.
Yeah, and I think that links into what I was going to talk about, what services are available in transition. The local offer does have a lot of information on there, and that's a website that's on the local authority, and we can share the link after today, and it takes you to a wealth of information around learning disabilities and learning difficulty as well, so both on there. In relation to what services are available, they're very different whether a person has that learning disability diagnosis or whether they only have the learning difficulty diagnosis, and I think that's why Claire picked that up, because we have to be really clear what services are there. There's a lot more doors open for someone with a learning disability diagnosis if it means supporting them to independently travel or access independent living. If that person doesn't have that diagnosis, then some of those support services aren't there, so it's quite individual. But what we're doing in the children's team the CCG is developing the GP TeamNet page. It's been revamped considerably by Anna, and we're hoping to launch that at the end of December, and we're going to keep trying to update that on all of these types of issues and services available. So just watch out for that for some really good information, and we're really happy to take feedback on it once it's launched as well.
Thank you.
Barry's just joined. I don't know if you want to go through any more questions or move on.
Well, I've got a couple of minutes if there are any more questions. It'd be nice to deal with them if there are any. No more? Possibly not.
There's no questions in the chat. No.
No, that's fine. Okay, thank you. Barry, thank you so much for joining us. You've actually got slightly more time than I originally allowed you. So thank you very much. I'm going to let you introduce yourself fully. I did do a very brief overview of the presentation, but it'd be really helpful, Barry, if you would introduce yourself. We are being recorded, and I hope that's acceptable. And just to say that you'll get a 5-minute warning, and I've lost my slot to tell you when you're going to get a 5-minute warning.
It's a 1:15.
Thank you very much. 1:15. Barry, we'll give you a 5-minute warning if we think that you're going on. But basically, please, over to you. Do introduce yourself and the topic. And thank you, Dawn and Catherine.
Thank you, Claire. So my name is Barry Ingham. I am a consultant clinical psychologist working in Cumbria, Northumberland, Tyne and Wear, and work clinically with autistic adults. And I also have a role within Newcastle University looking at a number of research, leading and joining in with a number of different research projects which are aimed at developing and evaluating new interventions for autistic adults who are experiencing different health conditions, including mental health conditions and physical health conditions. And I'm here today to talk about one of those research projects, which is the development and trial of a new health check for autistic adults. So I can move on to the next slide. Great, thanks. And so just the background of why we're doing this and why we're doing this in the northeast of England and where the ideas have come from for this. There's a research charity called Autistica who have and continue to fund a number of research projects, including some in the northeast and across the country. And back in 2018, they held a 2-day meeting in Newcastle, looking at establishing research priority areas for improving the physical health and well-being of autistic adults. And within that 2-day meeting, a number of different research priorities were identified, but one of the key ones was the development of a health check for autistic people, which also included the use of a pre-appointment tool. And so from that 2-day meeting, there was a funding call, and we were successful in the northeast, and a large consortium, including partners from around the globe, as well as different clinical academics within this country, successful in getting funding to do this health check. So next slide, please. So the program of research itself was aimed at looking to identify what are the barriers and potential facilitators for healthcare access for autistic adults, and also to help try and identify what are some of the reasonable adjustments that autistic people may require to improve the accessibility and also effectiveness of healthcare. And then the kind of main objective was to develop a health check for autistic people for use in NHS primary care, which is what I'm going to talk about here today. And that health check includes both the pre-appointment tool development, which I'd mentioned before, and also the development of health check template. the funding for the project was from Autistic itself, and also particularly when we say stage 3, that means the trial for the development of the trial was a large amount of funding from NHS England, which linked into NHS England's long-term plan for autistic people, which also included the piloting of health checks for autistic adults. So next slide, please. So just before going on to the health check trial itself and giving a bit more details about that, and also how you might be able to participate in the health check trial, I just wanted to give you a little bit of information about how we gained views on the development of the health check. So the first bit is around looking at a survey that we did of autistic people on health checks, and also secondly, I'll look at interviews and focus groups that we did for with autistic people and clinicians on development of the health check itself. So just focusing on the survey first. This was a national survey that we did to look at people's views of health checks, and we got responses from around 450 people out of over 900 people on a cohort of autistic adults that's run across the country. And next slide, please. And just summarising some of the main findings from that survey. The first one was that there was a strong positive view about having regular health checks for autistic people, and also a positive view of there being an opportunity for autistic people to be able to provide information beforehand, both on the health conditions they experience and also on some of the regional adjustments that they may need. Also, some of the features that autistic people thought would be helpful in a health check, very important in a health check, were that clinicians would receive training about autism, so autism awareness, but also training about how to do health checks, and also that the health check would be of a sufficient length to allow time for discussion and processing of information for autistic people. Next slide, please. And just in terms of the conclusions from that survey was that, as I said before, autistic people are positive about the development of a health check for all autistic people in the UK, and that it should be offered to all autistic people regardless of their ability level. There's a strong need for training in autism and for delivery of health checks. There's some lesser agreement about some of the more specific aspects, such as the age at which you'll start for our health check that we developed for this trial. It's from 18 plus, but there's been discussion about whether that should be offered to people who are younger, in a similar way to the learning disability health check, and also how long the health check itself should take, with about a quarter favouring lasting between half an hour and 3/4 of an hour. Next slide, please. So just moving on to the interviews and focus groups that we did with autistic people and also primary care staff. This was really about trying to develop the health check itself and the pre-appointment tool. So gaining people's views on how that should look and the content that should be in that. We ended up speaking to just under 70 people, with a split then of autistic adults and primary care staff, and also people with learning disabilities. Next slide, please. And just some of the key messages about what the health check should look like and how it should be delivered. In terms of reasonable adjustments, there was a a strong agreement that reasonable adjustments should be in place by the time that someone comes to an appointment such as a health check, that those reasonable adjustments should be tailored to individuals' needs, that there's some particular health adjustments that should be more likely to be offered, such as being able to wait in a separate room or a quiet area, being able to bring someone who knows the person well to the appointment, making the environment low arousal, adapting communication style, offering log appointments, being seen on time and consistent clinician. And that those reasonable adjustments should be recorded and be visible to all staff. Next slide, please. And just developing that a bit further, autistic adults, talking about the importance of having supporters who can help them through the health check process, the importance of training as mentioned before, and some awareness of not only of the needs of autistic people, but also in particular some of the sensory issues that people might experience, such as difficulties taking tablets. And primary care staff themselves also talked about some of the need to manage expectations to make sure that it was clear that not every adjustment could be offered. Next slide, please. And so in terms of the health check itself, there was a fair bit of agreement on the importance of the pre-appointment questionnaire, which is a way of gathering together information so it doesn't need to be repeated in the health check itself. The importance of being able to offer materials in different formats, the importance of having a health check which was biopsychosocial, so included identification of social needs which could be signposted, that there was a balance between including everything and not overwhelming people, both in terms of the pre-appointment questionnaire and also the health check itself, and that there'd be a written summary or an action plan which could be shared with patients and other people. The next slide, please. And just in terms of the health, these things that I've really mentioned before, that these things that the materials being offered in different formats, the health check itself being provided in person or video or perhaps through email consultations, primary care staff talking about the concerns about raising expectations, and there need to be IT solutions to make sure the health check's integrated, and that there's an option for people with learning disabilities who also experience autism to have an autism health check which meets their autistic needs. So next slide, please. So moving on to the trial of the health check, how it's been developed. These dates are slightly wrong because we've been affected by COVID. So we've got the health check in place. We have ethical approval. We're planning to start the trial in 2021. The trial itself will look at a number of key things. First of all, the feasibility and acceptability of the health check in primary care. Secondly, whether it improves access to healthcare for autistic adults, thirdly, whether more health conditions and other needs are identified through the trial, and whether it's a cost-effective thing to be doing. The plan is to recruit about 200 autistic adults with about 100 people receiving the health check and 100 people receiving treatment as usual. The randomization to whether people get the health check or have treatment as usual will be based on GP practice, and GPs will have funding to undertake the autism health check. Next slide, please. This is just an overview flow chart of how the trial will work. We'll recruit GP practices. They'll be randomised into either the health check group or treatment as usual group. The health check group will receive training in autism and delivering the health check. They'll then deliver the health check and there'll be outcome measures. The treatment as usual group will people will continue to receive healthcare services as usual, and outcome measures will be completed. There's a plan for people in the treatment as usual group to still get autism training, but only after the recruitment and delivery has completed. And the outcomes, the primary outcome is the whether or not the health check is able to identify new health needs. And that's both at the health check, but also looked at follow-up at 9 months. There's also some secondary outcome measures, which are on the next slide, which are looking at things that you'd expect to see within most trials of healthcare interventions, such as, are there any adverse events? Does it make things worse for people? We think that's unlikely, but we still need to look at that. Looking at health promotion, health monitoring needs being met at 9 months, the changes in general health at 9 months, any other needs like social needs being identified at follow-up, and any changes in health and social care usage over time, particularly thinking about whether the cost of with the cost of the health check make it a cost-effective tool or not. And then finally looking at the views of autistic professionals about autistic people and professionals about the acceptability of the health, its utility, and how it may be used in the future, particularly thinking about implementation. And I think the next slide.
Sorry to interrupt, Barry. 5 minutes left.
Okay, great. Okay. So just at this is just some more information about some of the health economics that's there. I won't go into detail around that, but it's there if people want to see it, around how we will understand some of the cost effectiveness, thinking about particularly quality of life changes that happen at follow-up for people participating in the health check. And next slide. And this is just an overview of the timeline. I think hopefully this is the right date here rather than the other one before. That we do have some potential GP practices identified so far. And we're now looking in the process of trying to identify further sites so we can start to recruit sites into the trial. And then in the new year, we'll be looking at, once practices are randomised, then we'll be looking at training of GP practices, and those GP practices starting recruiting autistic people to the trial. Obviously depending on whether there's any impact of COVID-19, hopefully not. And then we'll be looking at the trial recruitment complete, which you can see now the dates aren't quite right, be the recruitment complete in 2023, and then the final outcome in 2024, and then the results being available in the summer of that year. I think next slide, please. So this is just an overview of all of the different consortium members. As I mentioned earlier, we have both local clinicians, GPs, including yourself, Claire, and Sebastian Moss from Northumberland, and also GPs from other parts of the country, such as Carol Buckley. We have autistic people as part of the consortium, and also clinical academics, including people who've developed health checks, both in this country, such as Anna Cooper, and internationally, such as Nick Lennox and Christina Nicolaides. And also the consortium involves some commissioners and other people representing other autistic agencies, such as the National Autistic Society. And the next slide, please. If there's a next slide. Yeah. So just a thank you to the funders, Autistica, Peter Sowerby Foundation, and NHS England. My email address is there. If you are interested in taking part in the health check trial, which I really do hope that you are, then please do get in touch with me, and I'll make sure that details are forwarded on to be contacted back again. And I think that is me.
Thank you. Thank you, Barry. That's brilliant. And to time, I'm very impressed by people's timekeeping today. Thank you so much. There is a break now till past, but if anybody wants to stay and ask any questions while we've got Barry, is anything in the chat, please feel free. And if not, if you're desperate to go and get your cups of tea, I understand. Anything coming up in the chat?
Just a suggestion to add that information to the CCG bulletin for practices who aren't on this session, so we can do that.
I think, Barry, would you update those dates before we do that?
Yes.
Because we've had a COVID hiccup in that, haven't we? So that'd be lovely.
Yeah.
So lovely. We'll certainly do that. We'll let Barry have a bit of an opportunity over the next week or two just to update the dates on it, and then we'll just put that out. That's lovely. Thank you.
Yeah, that'd be great.
Thank you. And anything else?
No, nothing else in there.
Lovely. OK, it is break time. Thank you, Barry. I mean, you're very welcome to stay for the second half, but I imagine you have to go. But either way, thank you so much indeed. That's really helpful. Thank you. See everybody in 10 minutes.
Thank you for the opportunity.
Cheers, Barry.
Bye.
Thanks.
Hello, Helen.
Hello. How are you?
Hi, thanks for joining. I think everybody's just having their little gap at the moment, so I just thought I'd say hello.
Well, thank you.
Thank you for the slides, look great. So what I thought we'd do, so obviously you've got a bit more time because I'm going to do a few slides on epilepsy, different perspective on epilepsy. So if you can allow a bit of time for Q&A, but you aim to stop by 4.
I've just heard your comments about everyone keeping to time, and I'm notorious for failing on that score.
Well, you'll get a 5-minute warning, and then somebody will put your mic on mute.
That's absolutely fine. I'll do my best to rattle through. I'm sort of going through my notes and just sort of editing bits out. I
always think these things, you know, because I think it's difficult, isn't it, when you've got lots to say, but actually I've thought it was really nice and balanced what you've got, because it's a mixture of the clinical, isn't it, and then you've got the services as well, which I think is that nice balance to, but the bit I'm going to talk about is more about the leader stuff, but I think I've got Hemant Nagarathnam might be on the call, because originally I was going to have Reese talking about, you know, that interaction between specialist neurology and learning disability psychiatry, but of course Reese not being here, I don't know if Hemant will stay on the call or not, but yeah, anyway.
I don't know Hemant, Claire. Who's Hemant?
Okay. So Hemant is an adult learning disability psychiatrist who sits across Gateshead and Newcastle now. He's actually
lovely. Right.
So he was going to join, really just to have, if there was a bit of discussion to be had around that interplay. Obviously it's different for children, so because they automatically have a paediatrician such as yourself. So anyway, we'll it's just if it's quite nice just to have that last 15 minutes so I can just capture some of my stuff in there. Is that all right?
Yeah.
Lovely. And yeah. The one thing I don't know, Helen, is I don't know who's that. I haven't gone through the list to see who's on the call, you know, to identify who's admin and who's managerial and who's clinical. So you do have a mixed audience, I hope, as indicated before.
Oh, that's absolutely fine. So hopefully there's a little bit of something for everyone.
Yeah. Well, that's how I try to do these events, because I never want anybody to feel excluded. You know, we're sometimes asked to say who our meetings are for. And I sometimes feel, well, actually, we all as a team of healthcare workers actually probably have an interest in quite a lot of it. We may not feel it's our remit, or some of it may not quite up, but actually I would never wish to exclude anybody. So, yes.
Right. Oh, like you, I'm looking forward to that cup of tea.
I always have big adrenaline surges. It's a bit like sitting in an exam, these things. It's kind of like... Anyway, it's fine.
I just deal with them with coffee, or not too much coffee.
No.
And not too much to eat.
No, that's right. You don't want to be half asleep and fidgety at the same time, do you? No.
Yeah, I think you know, it's sad. I mean, my memories as a medical student are that the GPs were always there at the big lunchtime meeting and everything else, and it was lovely. And you'd see your consultant chatting away to a GP about some case or other. And, you know, that's steadily fallen by the wayside, and particularly, I think, in paediatrics. I don't know if it still happens in adult land, but particularly in paediatrics, you know, and we see lovely trainees come through, and we keep in touch a little bit with some of them, and, you know, smile when we see the names referring things in and everything. But, you know, you just don't get that contact, even before the pandemic. So.
No. So, I mean, this is a bit of an opportunity, isn't it, for just to hear about each other and what we're up to.
Yeah.
Just to let you know, this is being recorded. I'm assuming that's okay with you.
I thought you might say that.
Exactly right.
I'll do my best not to collapse in a heap.
We don't put it on YouTube anything though, so it's right. It won't come back to haunt you.
Actually, that's probably a good thing, because a couple of my scenarios are possibly recognisable to a select number of people.
Okay.
I mean, I have anonymised them to an extent, but
okay.
But thank you for warning me.
All right. So where are we up to? So we've got 2 minutes, and what I tend to do is actually suggest people start at the allotted time, which is the break is till 3:30. Mm-hmm. So if you start talking slowly while they come back.
Yeah. Oh, well, I have got an intro slide, so that's all right.
Yeah. No, I did a very, very slow start and attempted to run a nice little YouTube clip on adult not brought, and it just didn't work. We'd all tried it beforehand many times. Brilliant, and then of course it just.
I have as you know, I have no video clips because I just don't trust them.
No, I think you're right, based on my experience today.
I can do them on my PC, and I do when I'm teaching, you know, in person, but I cannot, you know, within a presentation, it just seems fraught with disaster.
Yeah. Okay.
Right,
so,
we're nearly there, aren't we?
I think we are. So have we got Tracy and Anna back with us?
Hi Claire, I'm back on.
Hello. So for Helen, I'm giving her sort of up till 3 o'clock, but that's including Q&A. So perhaps if you give a 5-minute warning at 10 to.
Yeah.
Helen, I'm putting you under pressure here. Helen may push us. She's already declared that. But then that gives just a little bit of space to give us a second. Right, you mind that? Could we stop now? Because there may be some Q&A, and if not, it just gives me a little bit more time. I'm pinching a bit of time back potentially.
Okay, I'll come on at 10 to.
Yeah, but don't worry, Helen. That is giving you a little bit of extra wriggle room, so don't be too panicked by that.
Yeah.
Yeah.
So who's got the slides?
Yeah. Anna, I think Anna's there, is she?
Yeah, I've got them.
Lovely, thank you. So shall we slowly start, and I'll turn my camera off. Lovely, thank you, Helen.
No problem. Hello and greetings from Clinic Room 4 at the Paediatric Outpatient Department at the QE. I'm Helen Eston-Jones, who some of you will know. I'm one of the consultant paediatricians with an interest in epilepsies and related conditions. Next slide, please. So thank you for the invitation to talk. I've tried to put together something which I hope will be relevant to you in your work here in Gateshead. I thought you might be interested in how your referrals are handled, how the children and young people that you see fit into the bigger picture, some of our challenges we face in clinic, what we have been up to and what we're working on, and of course some suggestions at the end for you. And I'd love to hear from you about your experiences and ideas about epilepsy and how we could improve the service, perhaps via email or in the chat as time is short. Next slide, please. You know the reality for many of our some 40,000 children and young people growing up in Gateshead, but I don't know if you're aware of the key findings of the National Child Mortality Database. And at the top, they've got a clear association between risk of death and level of deprivation for all causes of death except malignancy. And that, of course, includes epilepsy. And under this deeply unfair mortality gradient lurks an iceberg of morbidity. And for long-term conditions like epilepsy, chronic health problems. Next slide, please. So we've set about assessing the need in Gateshead, and you can use standard measures of prevalence and incidence as quoted by NICE, which reckon on 70 to 140 children and young people with epilepsy in our population, with 20 to 25 new diagnoses a year. But with our health deprivation, we've always known that this is probably an underestimate. We have around 150 children and young people with epilepsy. If you remove the 10% that choose to come to the QE from out of area, that's still at the upper limit of standard estimations. And our caseload grows by 1 to 2 new diagnoses per fortnight. So that's more like 30 new diagnoses a year. And some epilepsies clearly remit, some are lifelong and require transition to adult epilepsy and other services. So we tend to achieve a steady-ish state, we hope. A third of the children that we see are treated in, are followed up in neurodisability clinic, and they have more significant additional needs and often in special schools. Overall, 70% of our caseload meet criteria, NICE criteria for referral to tertiary neurology. Sometimes this is because we're uncertain of the diagnosis. It may be because of complexity and comorbidity, but very often it's due to lack of seizure control. 2 years seizure control not achieved, 2 anti-epileptic drugs tried, seizure control not achieved. And this is important because lack of seizure control, that's the treatment gap. That's the difference between those who could could be seizure-free, estimated at 70% of those living with epilepsy, and those who are seizure-free, which is thought to be around 52% nationally. And clearly we need to do some work defining that better for our population. And this is where the greatest risk lies, and those modifiable risk factors often linked to poverty persist. We also suspect that linked to deprivation, although epilepsy numbers have declined slightly, we suspect that epilepsy is secondary to conditions associated with poverty. So by that I mean extreme prematurity, birth complications, vaccine preventable diseases, head injuries of various sorts are probably overrepresented. Again, another piece of work for the future. There's a good evidence that living with epilepsy makes you and your family poorer, as well as increasing your risk of death. So even if your epilepsy is not life-threatening, it tends to be life-changing, particularly if you don't have access to the necessary services and contributing, of course, to further health deprivation. Next slide, please. So when I last spoke at TITO, NICE had just published guidance on epilepsy, followed by quality standards against which we've been measuring our service and using, amongst other things, the Epilepsy 12 national audit, which is now in round 3. And we've made some changes which I hope some of you might be aware of. I think importantly, we have gone from around a dozen paediatricians all seeing a few children with epilepsy to everyone with suspected seizures being seen as soon as possible by one of 3 paediatricians with expertise, and we have a mix of other skills as well. We've set up a weekly suspected seizure clinic, and this has really helped cut waiting times from first appointment from months to weeks, and in some cases even days. It's midweek, so I can even pick up referrals from A&E from the weekend, and if I've got a slot, talk to them on the Wednesday. And we're using face-to-face, video and telephone, which were innovations that came in under the pandemic pressures, as for many of you. We've also created a weekly epilepsy follow-up clinic, as well as community and neurodisability slots if more appropriate. To be seen by that particular consultant. And we think that being seen by a paediatrician with expertise has reduced the number of inappropriate requests for EEG and MRI, which is obviously a big deal for some children and young people, particularly with additional needs. And we've also worked to increase the use of detailed epilepsy protocols and online neuroradiology reporting, and all that's contributed to us being able to get those investigations done, those first-line investigations done in a more timely manner. Outpatient clinical coding is obviously really important. It's amazing that it wasn't done, but it's helping us to keep track. And due to improved capability at the QE, we've been able to work with our link neurologist to improve new to follow-up ratios in the regular outreach clinic, and so reduce waiting times for neurology opinion. Next slide, please. So looking at the suspected seizure clinic, one of our registrars did an audit of time to first appointment, as well as outcomes for the second quarter of 2019 and that momentous second quarter of 2020, the start of the pandemic. Referrals were down, especially from you, and we speculated that this might be due to families just not presenting, staying at home, as well as understandable assumptions about non-COVID service cancellations. We didn't do so well on meeting our 2-week wait target as we rapidly pivoted to telephone clinics, then video clinics. Overall, more than half who were seen were not diagnosed with epileptic seizure or epilepsy, although this proportion fell during the pandemic. And we speculated that this was, again, probably due to families not presenting and you not referring, and A&E colleagues not referring, or perhaps not even seeing vague episodes. And early in the pandemic, we ran on a pretty skeleton staff, and telephone and later video was really helpful because as planned care resumed, I'm sure you all face the same problems in your surgeries. We just didn't have enough larger clinic rooms for distance consultations. Next slide, please. From a clinical perspective, I derived from the first seizure clinic. I have a caseload of nearing 100 confirmed diagnoses of epilepsy, and this increases, as I mentioned, by 1 to 2 per fortnight, although we share some of those out. The seizures that I see most of and the epilepsies I see most of, childhood epilepsy with centrotemporal spikes. Some of you might know that that was previously known as benign Rolandic or benign epilepsy with centrotemporal spikes. Also childhood absence epilepsy, so a lot of primary school age children, juvenile myoclonic and juvenile absence epilepsy. And then I have a smattering of other self-limiting focal epilepsies, formerly known as benign focal epilepsies of childhood, and other less common epilepsies, some of which are quite a challenge and have significant comorbidities. We also see some pretty atypical febrile seizures, some of whom go on to have generalized epilepsies in later life and may have genetic variants that run in their families. A significant percentage, perhaps 50%, remain unclassified beyond saying they're a focal or a generalized seizure disorder. And that's actually, I did feel bad about it, but actually it's pretty comparable with colleagues nationally, even neurologists. Next slide, please. So although I said that 1/3 of our total caseload are seen in the neurodisability clinic, usually by Dr. Walney, with significant comorbidities and often in special schools, my caseload actually contains quite a significant number of children with additional needs, some of them at special schools, others in mainstream, and other long-term conditions. And you can see some examples there. And we also, and of course these children will have, you know, the ones who have migraine, I manage their migraine. I try to coordinate care for those who I suspect have ADHD or autism who haven't yet been diagnosed. And in addition, you know, we have these challenges of working with children in long-term foster care and the percentage that are out of area working across local authority boundaries. Next slide, please. Oh, that's not thank you. So what I was going on to say, sorry, if you can find, what is it, slide number 9 possibly? There's all the spoilers coming out now. We have, because of the structure of the suspected seizure clinic, I said more than half of them are not epilepsy. So where do they go? I think that's the next slide, please. And the next one. That's brilliant. So I end up with at least 100 children, young people without epilepsy. And the typical things that I see are going to be syncope, reflex, asystolic syncope, breath holding, parasomnia, lots of things happen at night. Stereotypies in children either with autism, where people aren't sure or not yet diagnosed, tics and Tourette's, migraine-related conditions, and occasionally some rare sort of movement disorders and unusual neurology. And I think that these all require explanation, at least sometimes investigation, and often some follow-up, because I think it's really important that these families have a fairly knowledgeable point of contact for future events to avoid misdiagnosis, but also someone who's prepared to keep an open mind and say, actually, you know, let's think again, let's revisit potential epilepsy diagnosis. And also, you have to bear in mind that for children and young people with epilepsy, every event, every unexpected event particularly, needs to be assessed on its merit. So a teenager with epilepsy might also have syncope. It's much more common. And most non-epileptic attacks actually occur in young people struggling with epilepsy or other challenges, which are often school-related. Next slide. So in terms of what we do in the first seizure clinic, it's very much about diagnosing the event using a detailed eyewitness account and as much information from the child as possible, which you can imagine for some of the young people I see is quite challenging. The eyewitness is not always the parent who accompanies the child, so a telephone comes in handy again there. And I have been known to actually telephone them from clinic and speak to the other parent or the school teacher to clarify if time allows, or after clinic. And when I'm stuck, what I often fall back on is a mantra that I sort of came across in paediatric epilepsy training run by the British Paediatric Neurology Association, that most epileptic seizures are largely unprovoked, they're brief, they stop within a few seconds or a few minutes, They're of sudden onset and sudden offset, so they're paroxysmal, there's a definite change. They're self-terminating, and they're a fairly stereotyped disturbance. The same thing tends to happen within that seizure type each time. And they're fairly unpredictable beyond things like an intercurrent illness or their relationship to sleep. And what you really need in order to reach a diagnosis, I think, is time. I take an hour for a first seizure assessment. The neurologists take 40 to 45 minutes. A large part of my first meeting is spent on things like safety, supervision, what activities can they, can't they do, risk assessments, things like that. So that's where the extra time goes. Some knowledge, I think not only what epilepsies are likely, what seizures that might be, but also what differentials are likely. And a framework, and again I fall back on a framework from paediatric epilepsy training called DESCRIBE, which stands for D, which is the description of the event, and it really wants to be as detailed as possible. It is almost like the biopsy in epilepsy, deciding whether it's epilepsy or not sure, the seizure type. And the way we talk about seizures has changed. The seizure syndrome, that's the sort of epilepsy, the epilepsy category, the diagnosis. The cause, C is for cause, relevant impairments, behaviour, and either emotional or education. There's always an impact on education. And so I use that as a framework for making sure I've got everything covered. However, what I often fall back on in clinic, and what you would probably find most useful in surgery, is that idea of what things are likely at what ages and what differentials should I be considering. And it's always the first thing a paediatrician asks you, isn't it? While you start telling them their history, they'll interrupt you and ask you the age. So I thought I'd go through some ages and stages for you, and have a couple of brief digressions on diagnostic dilemma and some management issues at the end. So next slide. So apart from a few uncommon events like fifth day fits, which may or may not run in families, you can't go far wrong with newborns if you assume that all seizures or suspected seizures are acute and symptomatic. Hypoxic newborns are usually on SCBU or the neonatal intensive care unit, hopefully being cooled if they meet those criteria. But you might be looking in surgery at an irritable baby who's not been waking for feeds, who might be hypoglycemic, which you can do something about, or might have late onset would be strep, or might have an inflicted head injury, all of which I know you would refer acutely to my acute colleagues in A&E, and all of which risk lifelong complications, including intractable seizures in later childhood. And we've got examples of those in all our clinics. Next slide, please. Later in infancy, to quote one of the neurology colleagues, things are either very bad or they're not. In terms of most things being not too bad, there are lots of non-epileptic events, and I think of benign neonatal sleep myoclonus, tonic up gaze of infancy, spasmodic torticollis, shudders and judders, and there are a few sort of self-limiting focal epilepsies, as well as, of course, the start of the febrile seizure epoch. The things that we don't want to miss are the early epileptic encephalopathies. These are the really severe aggressive epilepsies where the EEG is so chaotic that it completely disrupts normal brain function. That's the definition, isn't it, of an encephalopathy, and the child tends to regress. So the big one to look out for is epileptic spasms. They can be tonic spasms or infantile spasms, and there's been a lot of awareness raised about that. And I saw a little baby acutely referred last week with parents concerned about infantile spasms because they Googled symptoms and they were worried that it might be that. And I could see where they were coming from, but actually it was much more related to reflux, and that's a common precipitant for unusual movements in early infancy, isn't it? Along with infantile spasms, often goes developmental regression, particularly if they've been established for a while and unrecognised. And it's really key, just get them referred to the my acute colleagues, suspected infantile spasms, and they know what to do in terms of liaising with neurology and getting an urgent EEG, with all the investigations that may or may not follow. Febrile seizures under 6 months are unusual. They're often a bit atypical, and what I've learned is that they are a bit of a red flag for more severe epilepsies, and particularly one called Dravet syndrome. And we have a little girl who I first met when she was about 4 months old with an atypical febrile seizure, somewhat focal in nature, and she's gone on since 6 months old to have a very difficult, intractable epilepsy with developmental regression. Not so urgent as infantile spasms, but still prompt referrals appreciated. Next slide. Into toddlers and preschool. Febrile seizures is the big seizure event for many toddlers. Typically, as I'm sure you know, at the start of a febrile illness, brief, bilateral, convulsive, very frightening for parents, particularly when it's prolonged, as a significant proportion can be. The main differentials of other events include non-epileptic events, and the typical ones I see are breath holding and a particular form of syncope. Breath holding, the other name is forced expiratory apnea, which gives the clue. It's the upset child who cries a few times, and as they exhale, their mouth is usually open. They can't or won't, as the parents say, take a breath. They often turn grey or blue and collapse to the floor, sometimes rigid, sometimes convulsing, and seconds later, seems like a lot longer, take a big breath. And it's upsetting and very tiring for everyone. The other one, the reflex asystolic syncope, you may also know as reflex anoxic seizures. It often starts more in girls than in boys. A sudden minor bump or shock, some upsetting experience. They may not cry, but they typically drain of colour. They go really pale. They collapse unconscious, sometimes convulsing. They have a fairly rapid return to consciousness once they've collapsed, but they're usually quite tired and emotional. And reflex asystolic syncope is possibly a better, more accurate description than reflex anoxic seizures, as the physiology is all about increased vagal tone, reducing heart rate, brief cardiac standstill, drop in blood rate, reduced cerebral perfusion, and loss of consciousness. So it kind of helps in terms of informing your first aid strategies about lying on flat and lifting their legs, just like you would in other reflex syncopes elsewhere in childhood. Next stage.
Sorry to interrupt you.
I'm going to run well over. I'm really sorry. I'll truncate this slightly. So in terms of the sort of the key stage 1 at school, the big ones are Rolandic seizures in childhood epilepsy with temporotemporal spikes. And I think the typical history that I get, because this affects the oromotor area, the perisylvian area, with or without loss of awareness, sometimes, evolving to involve a side of the body or generalized seizures. The typical story I hear from parents is, we were woken by the sound of him choking and gagging, sitting up drooling, looking frightened, and often back slaps are given and all those sort of choking child maneuvers. Sometimes afterwards, well, very often afterwards, the child's unable to speak, or their face might be quite droopy. And it's not unusual for me to hear something like, oh, he had a similar choking episode a year ago, which was put down to his large tonsils, which are of course common at that age as well. And I get a lot of referrals for suspected absent seizures. And I would just comment that a typical absent seizure, which is what you see it's the only real seizure in childhood absence epilepsy, is one where the child has a very brief interruption of consciousness, usually less than 10 seconds, which feels a lot longer. So parents will often tell me, oh, it was 20, 30 seconds or so, which would be highly unusual. And so a tip is to count out the seconds on the clock, 1, 2, 3, 4, and before you get to 10, most parents are saying, oh yes, about that long. And they're also very frequent, so it's a 0 to 60 per day in the 2 weeks it takes to be seen in clinic. So there's every chance that I'm going to see one in my long consultations, but you probably won't in your 10 minutes. And when I'm confident about absent seizures, an EEG with hyperventilation is a great test, and it captures the seizures, which is really important, because if you can make a confident diagnosis of childhood absence epilepsy, you can start that little girl, and it is more little girls than boys, on one of the best drugs, which is sodium valproate, confident in the knowledge that they're going to grow out of it well before puberty, often within a couple of years. And it's not a drug that I would choose really as a first line for really any other epilepsy that I see. I'm going to skip, if you go to the next slide, all I'm going to say about the next few slides is that add into that the difficulties of children with autism, which is known for its brief blank or for its variable blank episodes, and you've added an added diagnostic difficulty, but there are lots of clues there in the history that can make things less epileptic. So little Jay with his episodes where he'd disappear under the table and go very quiet, and the family had adapted things and what you knew to expect these when everything was noisy, versus, if you can go to the next slide. Now he'd already had a couple of febrile seizures, or suspected febrile seizures, was having blank episodes, which were really largely unprovoked. And there was just this sense that he knew something was about to happen. So we thought, well, maybe absences, but actually maybe focal seizures. He's getting some kind of sensory sensation. Next slide. And indeed, his EEG showed a focal seizure disorder, and he's doing quite well on carbamazepine, which is certainly a drug I would never use if I suspected absent seizures. Next slide. And then onto the teens, and of course this is, you know, the later parts of primary school are quite quiet for new diagnoses. You might get the odd child with a fairly late-ish diagnosis of absence epilepsy, or perhaps some of the childhood epilepsy central temporal spikes, but actually things take off again as you near secondary school, and that's when we see juvenile myoclonic epilepsy, or young people presenting with their first generalized tonic-clonic seizure, juvenile myoclonic epilepsy, suspected absences, but you might also see them coming into clinic or coming into surgery with just sort of school difficulties and getting more disorganized, maybe weren't they absences. And you might even get them presenting as twitchy, clumsy in the morning, you know, perhaps suspicious of myoclonic seizures. Now, temporal lobe epilepsy is supposed to be one of the commonest epilepsies worldwide, but for some reason we don't seem to be seeing very much of it in Gateshead in the under 18s. It's not a condition I'm coming across. Maybe that I'm just not looking in the right places. But more than juvenile absence on myoclonic epilepsy, what I see most of is syncope in all its forms. We've got pre-syncopal symptoms, a lot of that as well, and we see convulsive syncope and all the reflex syncopes, so heat, hair brushing, stretch syncope, all these have been seen in clinic, and we see them every year. And the diagnosis is in the detail there. And of course, as mentioned before, non-epileptic attacks, particularly in those with epilepsy and or school difficulties. And syncope in particular, talking to families about their parents' experience of epilepsy diagnoses and things like that, I think, and nationally as well, I think that it is in syncope and convulsive syncope that a lot of misdiagnosis has happened in the past. And that's, of course, of huge cost to the individual and to society. If you go on to the next couple of slides, I'm only going to say that teenage treatment gaps are really important. Aside from the very fragile child with other complex conditions, it's in the teenage years that the young person with generalized tonic-clonic seizures, and particularly at night, is most at risk of harm. And that's what happened for 14-year-old B with a very difficult backstory. Next slide. Who we were considering changing to valproate, but while we were thinking about it, she missed her doses on a night away and was found unresponsive and unrevivable. Next slide. And now with a very similar young person, with very similar sorts of seizures and problems. We've worked very, very hard to get her recurrence of seizures back under control, cycling through quite quickly through a number of anti-epileptic drugs, but eventually going back on valproate, because that was the only place that she and her mum felt safe. She's on a pregnancy prevention program, as you'll be pleased to hear, and is doing quite well on clobazam. I saw her in clinic yesterday. She's not had a generalized tonic-clonic seizure in over a year, but she does still have some clusters of myoclonic seizures. Next slide. I've told you about what we've done already. Next slide. Work in progress. The big thing that we really need is to continue advocating and seeking funding for a paediatric epilepsy specialist nurse, and that will make a huge difference across so many areas, some of which, well, in fact, single point of contact, links with SIPs and CAMs, mental health support within clinics, support groups, group consultations, transition to adult services, all will be vastly improved, as well as the thing that parents want, which is contactability with an experienced and supportive professional and care coordination. And supporting that, of course, we're working on our database, and we're about to introduce a dashboard to try and quantify all this. Next slide. And in terms of epilepsy, as you know, ICS is coming. There's a new epilepsy lead to be appointed, and there'll be gap analyses which will hopefully bring us all up to speed in terms of our services. There's a burgeoning evidence base into what treatments work. There are things like children's surgery for very selected, very, very carefully selected patients who might benefit, as well as other non-medical treatments. I think genetics is a really exciting area, not so much for diagnosis, because lots of genetic variants map to lots of different phenotypes. But for supporting diagnosis and for perhaps producing better targeted treatments. And of course, personalised care, making sure that everyone gets the care that they need, that is relevant to them, and what matters to them is properly considered. And really recognising that even the most straightforward childhood epilepsy is an immensely complex and challenging situation for most families. And some of our families are very challenged already. So in terms of next slide, what you could do to help, I'm sure you've got other ideas. I think that keeping an open mind on events is really important. Next slide coming up is the last one, I think. Yes, so suspected seizure until seen in suspected seizure clinic. Help us meet the 2-week wait, so refer via RTS if you suspect seizures. Don't hang around on advice and guidance. Conversely, you're very experienced with syncope. If you think it's syncope or a non-epileptic diagnosis, I am more than happy to discuss that via advice and guidance. The 12-lead ECG, if you can manage it in surgery with a calculated QDC for all of those with collapse and convulsion. Otherwise, I'll request that up here at the QE. And support self-care, because there's no doubt that a healthy lifestyle is great, whether the diagnosis is seizure or syncope or something else. And it can help with learning, memory and anxiety. And it's something we spend quite a lot of time on. It's not quite social prescribing, but nearly there in clinic. Next slide, please. So that's a load of links which you may find useful. I put them all on one slide rather than scattering them through, so that Claire can perhaps send them around. And I'm more than happy if you want to contact me if any other resources I can help with. Do get in touch. Next slide.
Thank you, Helen. Brilliant, and I know you're under a lot of pressure there, so thank you so much. What I'm going to suggest is we pause questions for a minute, and I will just do a few of my slides, and then I'll try and allow just a couple of minutes at the end for any questions, because I'm also just going to continue a bit of a theme about epilepsy, but I'm not Reese, of course, so I'm not going to do the clinical bit. Next slide, please. So I just want to think about data. Helen's covered some of this already. Bottom right corner, prevalence of epilepsy amongst people with intellectual disabilities estimated to be about 22%, so significantly different from the general population. And the point above about number of deaths per year from epilepsy, of which about 40% are thought to be avoidable. Next slide, please. So this is just comes out of the mortality reviews of people identified as having learning disabilities, some learning points, which range from better integration, primary, secondary care, training of carers, whether family or social carers, technology. Next slide, please. So yes, so there's things about there's things about equipment. Leader picked up that some people have things like seizure monitors which weren't plugged in and things like that and weren't being managed properly. Keeping good records, that's social care. Local service reviews, which I'll come into in a minute because we are having some local service reviews at high level. So that's just some thoughts about leader. Next slide, please. So this is thinking about what can we do, thinking about leaders. So it's good medication reviews, it's being positive with people, recognising the impact Helen's described on quality of people's lives, although this isn't, hers was an a child discussion. Obviously the impact into adulthood, either new onset epilepsy in adulthood or continuation from childhood, can be massively disadvantaging, and people need a lot of support psychologically and physically at times. I would recommend you look at epilepsy action and SUDEP action. I've got some links in the later slide. When you think about the learning disability annual health check, think that epilepsy set of questions around it and think what you can do to make things better. Next slide, please. So national work, there's some work going on called Step Together, which is an aim to get any providers or anybody who overlaps in secondary and specialist care around the care of people with intellectual disability and epilepsy, and trying to get people to a basic good standard that is then maintained with the right skill mix. And so colleagues, Rhys Thomas, who would have been here today, he's involved with that. And I don't know if Hemant Nagarathnam has stayed with us on the call, but Hemant is our learning disability adult psychiatrist for Gateshead and for Newcastle. And I think it would have engaged with a bit of a debate with Rhys about that overlap between adult neurology, dealing with epilepsy, and learning disability psychiatry. Hemant, are you there? Do you wish to make a statement? Go on, make a statement.
No, it's something that I think my role as a psychiatrist, or our role as a mental health team, is sort of fairly limited. We just help carers try and understand the impact epilepsy has on people's lives, and when and how to use rescue medication. But the general and overall management lies with neurology, with Dr. Rhys and his team.
Thank you. That's pretty great. And I'm sorry you've only had a walk-on part there with Rhys being absent, but thank you. Next slide, please. So that's fine. Next question. I'm just going to go to my slides next, and I'm literally going to squeak. Right. So just to say, right at the very end, I put some links to potential practice activities. So these are some audit ideas. Women of childbearing age on valproate or more than one anticonvulsant, have they had pregnancy counselling? Look at the SUDEP action. You can register individually to get the risk management tool. And I've already mentioned the health check. Next slide, please. Yeah, and there's some more links. So last 2 or 3 minutes, any questions anybody's put in the chat?
There's none. That's a very nice comment, thank you.
Yeah, it's a lovely comment for Helen to continue with her slides.
Yes, I think that I'd be interested to know from the colleagues who've got on this call, is there an appetite to have an epilepsy session as opposed to a learning disability epilepsy session? I'd be interested either on this call or separately if you put that back to the CCG, soon to be the system, because I think this needs more time. So any questions, or are people desperate to go and have a cup of tea?
Claire,
yes.
May I make a comment? The issue about women of childbearing age and valproate. Valproate, as we know, is a very good anti-epileptic drug, and it is a sadness that we have to deny many young women that. I think this is where the importance of diagnosis and misdiagnosis comes in, because very occasionally you do hear about women who have not only been on valproate without any pre-pregnancy assessment, and obviously looking back in time, and we certainly have children with learning disabilities, autism, ADHD, who it's being attributed to their fetal valproate exposure. But also, you inevitably, historically, there's been a sort of up to 30% misdiagnosis rate. And I think the added tragedy is if that woman, and you can go on the STARS website, the St. Paul Trust website, and read the misdiagnosis stories of women often, and the tragedy of not only not having epilepsy but also being put on valproate and quite high doses because you're thought to be seizures aren't controlled. So that's just my plug for the Suspected Seizure Clinic. Thank you.
No, thank you. Very, very valuable point. So thank you. I think we're nearly at the end of time, aren't we? So
it's nearly 4:10.
Okay, so we're nearly coming to end. So I think that's probably we've run out of questions, have we?
Oh, Vinod's come back with, does pregnancy counselling still need to be done by our secondary care colleagues? Is it not just clogging the system? I think there's two parts to that, Vinod. I think the first part is in terms of reviewing the diagnosis. So you might have an older woman whose epilepsy diagnosis, as I alluded to before, might not be terribly secure. So that's about getting her to a neurologist specialist, to an epilepsy clinic to actually review her diagnosis. Secondly, if it is epilepsy, she might have been put on valproate at a time when it was considered a reasonable first-line drug. So there may be alternatives. However, if there's a clear indication from recent neurology reviews or diagnosis and everything that it is epilepsy and valproate is the only thing that controls her seizures, then I'm not sure. Probably a dialogue with them would be appropriate. But you would probably be involved in the pregnancy prevention program, as in my 16-year-old.
Thank you.
Can I just add to that as well? The answer is yes, Vinod. I think we still sort of counsel a lot of people because we start people on valproate as well for things like bipolar, etc. And I know this is about epilepsy, but just talking about the valproate. So we still do counsel people. It does cause the clogging of the system because we've got to do it annually. So a lot of the time we just kind of see people as a one-off, discharge them, and then sort of get them back in.
Yes, thank you. So a general point about valproate being an effective drug for different conditions, but women are in a very difficult position if they benefit from the drug in terms of treating themselves, but if they want to have a child, we know there's an association with valproate syndrome with consequences for their children, which obviously is really rock and a hard place, I think. But thank you both of you for those contributions. And I do think the GPs have a role in this, and I don't think we should assume that somebody else has done the counselling. I think it's really important that we raise those issues, and on the back of what Helen said, we think about, should we actually be asking, I know they're busy at the RVI, but should we be actually asking for adult review of the use of the medication to permit people to have more successful pregnancies. Thank you. So are there any more questions in the chat?
No more questions in the chat, Claire.
Okay, well, what I'd like to do is round up by saying many, many thanks to all the speakers and people who've joined in. I hope that was of use. These slides will be made available, and obviously I encourage you to just pick out some small actions, either from personal interest or professional work. And as I say, I'm very, very keen to know if people would like other topics for another year, subject to being offered TITOs next year, but particularly around epilepsy and whether people would like this taken away from the learning disability to actually have a full session on epilepsy. But thank you very much indeed, everybody, and thank you for the team at the CCG who have assisted with this, because it's been fantastic, and I wouldn't have survived without you. So, so thanks very much, everybody, and goodbye.
Thank you, everyone.
Thank you.
Bye-bye.
Thank you.